effects than sleeve gastrectomy or medical therapy alone isn't well established, and is something at the Cleveland Clinic has been a great focus over the last several years. So in collaborations with many endocrinologists, including Sandy Keshup and Phil Shower, the lead bariatric surgeon, we had undergone a sub-analysis to determine insulin and glucose metabolism. And individuals, 60 individuals undergoing surgery, were randomized either to intensive medical therapy with gastric bypass, or intensive therapy with sleeve gastrectomy. And we then conducted follow-up data 12 and 24 months post-operation to look at metabolic health changes. We used a mixed meal tolerance test to assess blood glucose, insulin, and C-peptides to help characterize not only glucose tolerance, but also insulin action in the body. And we also measured gut hormones, GIP, GLP, and acylated ghrelin during this test, also to gain insights into that potential mechanism. Now, with our treatment plan here, what I'd like to first highlight is in the before conditions, all individuals were type 2 diabetic, as indicated by high blood glucose levels and low insulin levels. Again, with being diabetic, there's a dysfunction in the ability to secrete insulin. So these data were quite nice in confirming our patient population. But as we look at the post-intervention, after the trial at 24 months, we notice that there are distinct curves in blood glucose, suggesting overall that Roux-en-Y gastric bypass had lowered the glucose variant curve compared to either sleeve gastrectomy or intensive medical therapy. And this was reciprocated by the stark rise in blood insulin concentrations during the test, suggesting overall here that gastric bypass lowers blood sugars the most. And it appears to be through an insulin-mediated mechanism. And when we had done calculations to look at beta cell function, we had found that gastric bypass had increased beta cell function most compared to medical control. And when looking at insulin sensitivity via the Matsuda index, we found that gastric bypass had increased insulin sensitivity the most compared to either treatment at 24 months. Now, interestingly, these findings were not paralleled by the changes in GIP. In fact, GIP went down following gastric bypass surgery, suggesting that this is not likely a play in terms of the improvements in beta cell function and insulin sensitivity. When looking at GLP, however, we found that GLP stimulation was very robust and tended to be different than sleeve gastrectomy, but was significantly different compared to medical control, suggesting that GLP-1 may be a partial mediator of diabetes glycemic control. We'd also looked at acylated ghrelin. Ghrelin is an important hormone, as we know, in terms of appetite regulation. And what we found here was, when looking at fasting ghrelins alone, sleeve gastrectomy was the only successful operation, or treatment rather, to lower this level at both 12 and 24 months. Yet, when looking at acylated ghrelin suppression, so now in response to the meal, we found that it was really Roux-en-Y that had the most robust improvements in ghrelin suppression. And this is relevant because it was only acylated ghrelin that correlated with improvements in pancreatic beta cell function, body fat, and GLP-1 levels. So it seems that the fasting levels, although changing in the sleeve gastrectomy, were not related to metabolic outcomes in our study. But there's vast literature suggesting that at least by lowering fasting ghrelin, you could have a favorable effect on overall appetite regulation and body weight maintenance. So in summary of these data, Roux-en-Y appears to be the most effective at increasing GLP-1 stimulation as well as ghrelin suppression compared to either treatment alone. And as I mentioned, this seems related to pancreatic function and body fat. But again, it's important to keep in mind that sleeve gastrectomy is also an effective tool for promoting weight loss. And a part of that weight loss mechanism may be related to the lower fasting ghrelin. But I think what these data highlight overall is that gut hormones, although important, may not be the sole answer in explaining diabetes remission or improved glycemic control. So really, how does bariatric surgery cure diabetes? After all, that's what we hear most of the time, that surgery is effective at curing the disease. And this is a very controversial topic. And really, for several years, people have suggested that people up to 85% of the population undergoing bariatric surgery may have remission. Yet more recent work out of our group had suggested that with Roux-en-Y, that's not necessarily the case. Although there were vast improvements 3 months after surgery, what we end up noting is around 1 year there's an inflection point such that people begin to relapse. And the statistics in our analysis based on ADA criteria of diabetes remission actually suggested that up to 70% of patients may not be in the remission category any longer, and weight regain may be explanatory factor. So this is a quite different message then in trying to understand how bariatric surgery plays a role and whether it's truly effective or exercise and diet are needed in combinations. But with this weight regain issue, it raises another question of what's the mechanism by which these people are relapsing. And in collaboration with Frank Gonzalez and gaining insights into macrophage inflammation, it's quite clear that pro-inflammatory states induce insulin resistance. And we know that when adipose tissue expands, it's recruiting macrophages to those areas to act as a pro-inflammatory signal to secrete more cytokines that could ultimately impair insulin action in the body. So when thinking of this then in terms of different adipokines, including low adiponectin, high CRP, or TNF-alpha, this could be quite important in terms of understanding diabetes remission because these factors play a role in multi-organ effects of glucose regulation, including skeletal muscle, the liver, and the pancreas. So when looking at this, it's important to think about, well, what's unique about responders in bariatric surgery? Do we have a sense of this in the literature? Because if we do, then perhaps we can better understand who's responding and who's not, and why there are these controversial diabetic cure reports. Currently, what's suggested at least is that older age, hyperglycemia, low fasting C-peptide reflecting beta cell dysfunction, and more diabetic meds in combination ultimately are key risk factors for people who are less likely to be responsive to surgery. Yet really we don't have a sense of biologically what role incretins may have as a predictive factor in humans, nor inflammatory markers. So what we had done is looked at this through our randomized trial to understand the interaction of incretins and inflammatory markers. And for sake of time, I'll just kind of skip the story to the point that we didn't see anything with incretins. Incretins were not related to diabetes remission at all, and in fact we found robust improvements in incretin levels within our non-remitters. But it was the inflammatory marker adiponectin that seemed linked to improvements in hemoglobin A1C 2 years following the surgery, and this correlated quite nicely with beta cell function improvements and weight loss, suggesting overall that adipose-derived inflammation may be a mediator of bariatric surgery responsiveness. So the question I have then, thinking about the next steps is, well, how do we optimize bariatric surgery response? Given that people are going to elect surgery at some point, I think it's important we think about how do we target different ailments in these individuals to reduce complications of surgery and overall improve metabolic health such that diabetes remission remains intact. At the same time, when's the best time to intervene? I had a great conversation with Amy Rothberg yesterday on this topic, and the fact that after surgery, they're beginning to see changes in relapse rates as early as 4 weeks. Does that mean that 4 weeks is the right time to intervene with some sort of potent intervention? I don't know, and neither did she, which made me feel better in the sense that there might be some areas of future research. I think really a lot of the talk I've focused on has been endurance exercise, but in this context, it may be important to consider resistance exercise, given that body composition changes, albeit fat to a large extent following surgery, there are vast losses in muscle mass. And this could contribute to longer-term issues in terms of resting energy expenditure and weight regain, as well as overall physical function. So, take-home message of all that stuff. In terms of treatments here, at least my current thinking of a 1 + 1 = 2 approach that Ms. Teresa taught me in 2nd grade is not necessarily true when it comes to medical practice. And really, when looking at this from a dietary, exercise, and surgery perspective, the responses are highly individualized, such that pre-existing hyperglycemia And inflammation may be key targets biomarkers for optimizing diabetes treatment plans. And I think future clinical trials in children and adults are going to be vastly important for further understanding evidence-based medicine in combined therapy practice. So with that, there are lots of people that, and smarter people that have helped me with this work that I'd like to acknowledge. In particular, Dr. Barry Braun from the University of Massachusetts and Dr. John Kerwin from the Cleveland Clinic for all their guidance, expertise, and mentorship over the years. And I'd be really happy to take any of your questions or critiques at this time. Thanks.
In regard to your work, a couple of questions. The whole grain study. So, was there something about the whole grains that was, or could be attributed to the effect on the blood pressure lowering was the most significant thing that you found there? Or could it be something related to the gut microbiome, perhaps an effect on, most recently, changes in short-chain fatty acids have appeared to play an important role in all kinds of diseases. And is this something that may be a potential mechanism as to how these whole grains could be working?
So the short answer is I don't know, but the long answer is yes. Yes, I'll start. The first part is I don't know because we're doing those analyses now. This trial had finished over the summertime, and the first priority was to focus on the clinical data. But now we're investigating mechanisms related to different nutrients related to whole grains, one of them phenolic acids, as we think some of those properties may relate to azoic acid, and actually similar to sulfonylureas and how their mechanism is to influence insulin secretion, may be partially related to this beta cell function improvement. But there's also going to the short-chain fatty acid piece is another area we're investigating. We did collect fecal samples in our patients over the time course of the intervention. And we're interested in that because, as you illuminated, short-chain fatty acids may actually be a mechanism in improving mitochondrial function. And it may help explain our substrate oxidation shifts, such that you have improvements in some sort of metabolic pathway that alleviates the stress on insulin signaling and glucose uptake. But from a mechanistic point right now, I'm not really able to comment, but those are some future directions we're looking for.
The other question I had to do with your the volume of exercise that you're prescribing. 70% of VO2 max. So, what type of exercise did they do, and what was the age of this particular population?
Yeah, that's a great question. So in terms of the VO2 max, so it ends up being about 85% of their heart rate max. These patients were older, overweight to obese, and individuals were doing mostly aerobic. Well, they were doing all aerobic training. Most of it was on the treadmill. We tried to conduct all of it on the treadmill as possible. Given the high intensity, particularly with this patient population early on, individuals found that to be difficult. So we had interspersed that in the earlier part of the training with cycling to continue the movement and get them acclimated to the individual exercise prescription. For the vast majority of the patients, they were able to tolerate the exercise on the treadmill. So I think overall, though, your questions are quite prevalent in terms of putting into the context of the population. And in some ways, that's what's made me wonder about a younger age, as young as children, in understanding, is this some biological effect of, say, duration of disease, prevalence, or background metabolic severity that's been occurring, or is this something unique about the underlying pathology and glucose dysregulation?
Go ahead.
So I have several questions that sort of center on the theme that I'll try to consolidate. So that theme is weight, body weight, and weight change. And even I think it's consistent throughout all of the spectrum of what you talk about, perhaps most easily recognized in the pre-gastric bypass work. So you talked about diabetes remission, but aren't we really talking about weight gain? And you sort of say that, right? But there's some dance around, well, maybe it's other factors, but isn't it mostly about, or almost exclusively about, what do you do to retain a lower weight? And everything tracks, all the negative stuff track with that. And again, perhaps you can layer that on to your other paradigms of the exercise training without control of weight loss and those types of issues.
Yeah, no, I think, I agree. I think weight regain is certainly a issue in inducing some sort of metabolic dysregulation. In terms of bariatric surgery, again, speaking with Amy and Karen last night, we had a really good talk at dinner about this, and that with surgery, I'm not totally convinced, even with Jonas Corner's data, that it's all about low-calorie diet. And even hearing Amy some of this exciting pilot work suggesting that, I don't know if that's the case because it's not the greatest data, but when looking long-term at individuals cross-sectionally who've undergone bariatric surgery and then are matched age and BMI-wise of those individuals, the metabolic profiles are very different. And at least at that point, it's suggesting that there's something about this idea of the rapid weight loss, this sustainability, and this profile that's going to also improve long-term duration, despite then changes in the weight over time. So that's one where I do wonder if surgery is doing something unique, independent of weight loss. And plus with the bariatric surgery, as you know, many of these effects are actually seen with days before any weight loss. And I'm not aware of vast literature suggesting all these other microbiome projects, which I do wonder if that'll be a player in the mechanism. But in terms of the end product, which I think is what we're just kind of interested in from a clinical point, it may very well be that caloric restriction is a vital aspect to that. Going back to some of the other work, like the metformin and exercise, that was actually quite interesting, and I think from an exercise point, that I never controlled feeding. That was not a design, that was intentional. And we had long debates on that topic. I didn't want to do it because at the time thinking metformin actually influences appetite regulating hormones. So the thought was to be exploratory somewhat and think, okay, well if metformin does do that, will affect weight loss from an exercise program where I'm not telling people what to be eating wise. And in fact, I think that's what happened, although I don't have the data, we haven't analyzed it. Because really we didn't look at OGTTs, and I think postprandial incretins and appetite responses may be more biologically relevant in this context. But within our exercise group, they didn't lose any weight, but they did lose fat. They gained muscle. So in that context, even thinking about the dietary data I showed that was unpublished, I think that's even more impressive than that in the context of no weight loss, but changes in the macronutrient composition, there is some relation to the sensitivity and tolerance. Which leads me to this curiosity of how altering macronutrient composition coupled with exercise and drug could play a role. There's certainly some animal literature right now suggesting that if you look at diet and drug, not with metformin, but more with GLP-1 agonists, you could get additive effects. I haven't seen this necessarily with metformin. So it's something there too. And with the dietary piece, the whole grain trial comment on the fact that, quite surprisingly there, it was an isocaloric diet. We measured RMR, applied the right activity factor. They lost steady weight over time, I think primarily due to the fact they ate more before, were controlling feeding to the T, and a control effect.
In your subpopulation that you did the OGTT, I know that the big group didn't lose the same. In your subgroups,
it was the same thing. Yeah, it didn't matter whether we parsed it out and looked at it different ways. Body composition, equivalent across. In that case, what I think's exciting is that it seems to be a whole grain effect now. There's no body comp. So I think at least overall, caloric restriction as a whole is a huge player in this. But as we know, depending on the mechanisms of exercise or drug, that could be very different. And how do you then explain diabetes remission? Becomes a fun academic discussion.
Well, I think we're about to be overtaken by
Okay.
biostatistics
Sorry.
students, so Nina, maybe you can follow up with Stu later, and thank you very much.